Well, testing, 1, 2, testing. Good morning, Ibrahima. Can you hear me okay?
Hello?
Hey, hi, Ibrahima. How you doing?
I'm doing good. How about you?
Very good. Let me just post this here for a second.
Okay, good to hear from you. You good?
Yeah, how's your setup? Let me check here because I want to get. Okay. Okay, very good. You can hear me, obviously.
Yes, I can hear you from here.
Okay.
How about in Miami? Everything is going well, family?
It's a little cool. Miami's like the rest of the world. It's slowed down the tourism. So, so it's a little different than most years. So hopefully things will recover. Okay, I'll be back in a few minutes. Let me see, is your camera working?
My camera is not working, maybe because I'm not in the panelist, maybe that one.
Okay.
Yeah.
Okay. You're in the panel.
I don't
Yeah,
have
yeah.
that
I
option,
to
yes.
know this interface, man. Oh, man. Hello, Harshad, are you there? You're probably at the hospital.
Hi, John.
How are you today?
I'm fine. How are you?
Very good. Are
Oh,
you in the hospital or,
no, no, I'm not in hospital. How are
okay,
you?
good, good. I was wondering, well, I can introduce Ben.
Yeah,
Uh, uh, well, I'll tell you what, why don't you, I'll introduce you, you introduce Ben, okay?
okay.
Because you probably know him better, right?
Yeah.
Okay,
Who's talking today?
I'll introduce you. Oh, Jao Almeida, he's a neurosurgeon from Mayo Clinic, Florida.
Okay.
He's never spoken, but he's an ambitious guy, and I think he wants to establish really in China and Japan.
Mhm.
And the name Mayo, when you say that, you listen. It's got an
Yeah.
excellent brand name.
Mhm.
It's just got a good reputation in this country. It does. Um, and I guess they're building. I don't know if it's functional, but they have one in Dubai. I don't know what if it's a full hospital or what. So you've been busy?
A little bit, not much, but yes, up on and off. Yeah.
Oh, okay, Dr. Wen, how are you doing? Dinky Wen?
Yeah, you just call me you can call me Frank.
I can
That's
call you
just
Frank?
a common. Yeah,
Okay.
I'm doing okay, thank you.
Okay, you have your camera working? Okay.
Yeah, my camera is working okay, just didn't turn it on.
Oh, okay.
Okay, you can see
Hey,
me?
there you are.
Yeah.
West West
Hi everyone.
China. West
Uh,
China. Yeah, most people just think of East China.
yes, exactly. Just like Shanghai and Beijing, the
Yeah.
most two popular cities in China, and we're in the West China, so uh, things are kind of different, but I'm trying to catch up with all of you guys. And
Oh yeah.
I'm a young surgeon, so it's also fresh to me. And thank you for inviting me to this
Well, we look
conference.
forward to collaborating with you.
Yeah, thank you.
we could continue to collaborate with
Yeah,
you. And
exactly.
I'm gonna give you my email here in the
Hmm.
chat. And anytime you want to do a webcast, just let me know.
Yeah, thank you.
Because the West is dying to hear from China.
Dr. Bennett,
Yeah.
yeah, I see it. I got your email.
Okay. That's how things start, Harshad.
Yes, we can.
Well, Dr. Goel is speaking in Brazil for webcasts.
Right.
Well,
When
yeah.
is he doing?
Well, he went there, as you probably remember, a couple of months ago to South America, and he really liked it. He really
Right.
liked it. He was surprised at the reception he got there, but people
Mhm.
knew him from neurosurgical TV.
Yes,
They walked up to him and said, "Oh, we know you. We've seen you." He was surprised. So he's going to do a series of uh, four webcasts.
it will be fantastic.
Yeah.
I just met him yesterday, day before yesterday. Mm.
Oh, where? In Mumbai?
Mumbai, yeah, Lilavati Hospital, yeah. Mm.
Oh, he's here. Oh no, that's not the right Goel. Yeah, Wan Lee, how you doing? Are you there, Wan Lee?
Hi, yes, yeah.
How you
I'm,
been?
yeah, good, yeah. It's okay. My
Well,
daughter's just,
I'm sorry.
actually, no, that's okay. I'm here, yeah.
Okay,
But I think I cannot see you. So we will start at 8
okay,
a.m., 8 p.m., right?
okay, well, okay, we can wait a few minutes if you want.
That's okay. That's okay. No problem.
Okay,
Actually, I just got a phone call from Bing Shi. He said he's on the bullet train, so he's the internet connection maybe not very stable, but it's
okay,
okay.
okay,
Yeah.
okay,
So
let's see, so.
today we
Again,
have
I guess
four.
I guess I'll introduce, the speaker, right?
Yeah, actually, yeah. Maybe I can introduce the first one and then see. Well, maybe I don't know if he.
Well, do you know
Yeah,
the speaker from
of
Mayo? Do you
course.
know?
Yeah. Mayo Clinic. I know.
Okay, so I'll introduce you first, okay? And
It's okay. Yeah.
and you want to introduce him, right?
Uh,
Oh, Ben
yeah.
is here. Ben is coming. All
Oh,
right.
yeah. So maybe yeah. If he
Yeah,
can,
maybe you got a
if he's available, he can
train
still
connection.
introduce. Yeah. That's okay. Yeah. We are flexible. No problem. Hmm.
Okay.
车次去向以免乘客列车。
哈
John.
哈
Hello.
Hello,
Okay.
Wan Lee. How you doing?
I'm in the
Hi.
train.
Let me get,
Happy
hold on.
New Year.
Please, Professor Zhao, please you introduce the speaker.
That's okay. Yeah. Very.
Okay. So Ben, how you doing? How you been?
I'm in the train.
Yeah, oh, okay. You
Yeah,
can't-
into
you can't-
another
okay.
province. Yeah.
Well, it got good reception. So, okay. Okay. See, Joe's on his way in.
Yeah, I'm here. Yeah. Okay. Yeah. But I cannot open my camera or I don't know. Hmm?
Okay, oh, he's here. Okay, he came at the last minute.
Hello, everyone.
Hey, good morning. Oh, Joe, how you doing?
Doing very well, thanks.
Well,
John.
you came
Hi.
at the last minute. Okay, we're ready to start. Joe, you met Ben Zhu, right? You know Ben.
Dr. Benzu.
Hello, John. Hi.
Very
Hi.
nice to see.
He's on the
Hi.
train.
Sorry, I'm in the train. So
Yes, you can't.
let Professor Zhao to introduce you.
Well, we like your dedication.
Absolutely.
That's okay. Yeah.
Just one
It's a
second. Just
pleasure
one
for me
second.
to be here.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from beautiful Miami Beach. We have the pleasure today of having Zhao Almeida from Mayo that's going to speak, and I'll let Juan Lee Zhao give him the introduction. Welcome, Juan Lee.
Hi, this is Ali. Hello, everyone. Sorry, I cannot open my camera, but that's okay, no problem. We are very glad to have our bi-weekly webinar of our Chinese Neurosurgical Journal come back in this new year of 2024, and Happy New Year to everyone. Now we have the two wonderful speaker for this the first webinar of this new year, and let me please allow me introduce the first speaker, Professor Zhao Paul Almeida from Mayo Clinic, Florida, and he will presenting the topic of focusing on the medial wall of the cavernous sinus and its endoscopic surgical anatomy. Okay, please, Dr. Almeida.
Thank you very much
Thank
for the introduction, Dr. Zhao. Thank you very much for having me here, and you and Dr. Bing Zhu and the entire, Chinese journal and my colleagues from China. It is my pleasure to be here and to talk with you and to share some of our work. And I hope that this is going to be a nice start of a nice relationship, because I'm a big fan of the work being developed in China as well. So let me start and get things started here. So, and please let me know if the connection is going well, because I'm not at home. I'm actually in the West Coast right now, so I'm trying a new internet connection here.
That's always precarious.
Okay, very good. So
Perfect.
I guess you can see my slides here.
Yeah, perfect.
Excellent. So it's my pleasure to be here. I'm João Paulo Almeida, one of the neurosurgeons, one of the skull-based surgeons at Mayo Clinic, based in Jacksonville, in Florida. And today I'm going to talk, as Dr. Zhao mentioned, a bit about the techniques in the medial wall resection, but I also going to navigate a little bit about around the anatomy. So I understand I have about 40 minutes or so, but please let me know if I need to go a bit faster, if I can go a little bit with more time, and I can adapt this presentation without a problem, please. So I have no financial disclosures, but especially since this is my first time, I like to share with everyone. I'm a very proud Brazilian. I'm born and raised in Brazil, and that's where I did my initial training as well, my residency training, and that's where my basic neurosurgical passion comes from, and my passion for neurosurgical anatomy comes from as well. I was trained by Dr. Evandro de Oliveira, someone very well known in the neurosurgical community that unfortunately passed away 2 years ago. But I believe that many of us who worked with him and share the passion for microsurgical neuroanatomy continue to work across the globe to spread the word about the importance of microsurgical neuroanatomy. I'm passionate about skull base and endoscopic skull base, and that took me to Canada, where I did my fellowship in skull base and neuro-oncology with Dr. Fred Gentili and his team at the University of Toronto. I also did a fellowship at the Weill Cornell, a summer fellowship with Dr. Ted Schwartz. And then I went to the Cleveland Clinic in Ohio, where I spent 1.5 years as an advanced skull-based fellow. And then after that time, then I finally moved to Mayo Jacksonville in November 2021 under the leadership of Alfredo Quinones Hinojosa, who is my chairman. In this connection, Dr. Oliveira was also an adjunct professor there. And that's how we came to be connected as well. So in terms of the cavernous sinus, we're going to talk about some of the, the tumor component, not the vascular component today, but there are 3 points in my point of view that are extremely important. Number one is the surgical related factors. And the first step of that is, your knowledge of anatomy. You need to know the anatomy of the cavernous sinus very, very well. Otherwise, it would be, in my opinion, impossible to move into the next steps, which include understanding of the surgical technique required to work in that space and to set up an experienced and multidisciplinary team that is necessary, absolutely necessary, in my opinion, to successfully work in that area. Patient-related factors, of course, we need to understand what clinical presentations we're dealing with, previous treatments, including previous surgeries and previous radiation, and expectations and quality of life. So, of course, if we're dealing with a malignancy in the cavernous sinus, the aggressiveness is different from those with benign tumors, and certainly so the differences in expectation of quality of life are also important. Tumor-related factors, certainly so the pathology, so it's very different when we're dealing with a pituitary adenoma, I would say a soft pituitary adenoma, or a chondrosarcoma, or a chordoma, versus a solid fibrous cavernous sinus meningioma. And also the anatomy of the tumor, that means where the tumor is extending to, if it is extending into the supraorbital fissure, if it is extending into Meckel's cave, if it is extending into the clivus, all of those points play a role here in our treatment. In terms of surgeon-related factors, those are my two mentors and people that unfortunately are not here with us anymore. People that I not only somebody learned from in several personal aspects. They had the same style in terms of understanding the most important points. Number one is passion. You need to be really, really passionate about what you're doing, and independently what that it is. If it is neurosurgery, which I believe we all share the passion here, that's great. And if your passion lies within skull-based surgery, then you should go for it. But that passion is necessary. Without it, you're not going to move forward, in my opinion. With the passion, you need to have hard work, because it takes a lot of work, and that means commitment about continuing to push forward despite the challenges that you're going to encounter. Perfection is what you seek, and that must be your goal, despite the fact that may be difficult to reach perfection. And microsurgical anatomy is or instrument. It's the tool that we need to use to achieve those goals. I'm very thankful and very pleased to share with you all this new space that we have here in Mayo Clinic in Florida now. I came here in November 2021, and basically since I came, we've been working on this with our colleagues in neurosurgery and ENT department. We opened up this beautiful skull-based lab in September of 2023, so about 4 months ago now. And we have 11 stations for trainees, 1 master station, each one of them with microscope, endoscope, a high definition screen, high speed drills, head holders. Basically, in my opinion, all the equipment that we need to have successful training in skull-based surgery, I should say microsurgery, head and neck surgery, lateral skull-based, and everything, of course, based on the practice and training of mastering skull-based surgery and skull-based anatomy. In terms of anatomy and surgical techniques, I'm not going to focus here in the transcranial aspect, but it's always important to remember and to master the concepts that we have from above. So from above, we have 2 ways to get into the cavernous sinus. The first way is through the roof of the cavernous sinus, and there we have 2 triangles: the clinoid space, that is just the anterior part of that roof, and the oculomotor triangle located posteriorly, which is a useful space to get into the cavernous sinus, as proposed by Dr. Dolence. We got the lateral wall, which is the second area, and here to get the cavernous sinus, you can work around the trochlear nerve, as seen here, and then you can work here in the supratrochlear space and in the infratrochlear space, and the other triangles really are triangles that expose the middle fossa. But with the endoscope, we can get into the cavernous sinus without the need to transgress this plane of the cranial nerve structures, and then you can get there through the medial wall and get into the superior compartment. You can get through the posterior compartment and anterior compartment here, going through the anterior wall of the cavernous sinus. So now you don't work through the roof or through the lateral wall, you work through the anterior wall or through the medial wall. And I like to divide this area, the cavernous sinus area, in a posterior medial space located behind the carotid and anterior lateral space located anterior to the carotid. I just think it makes it easier for us to understand that area. In terms of bone anatomy, and here really quick, we remember that when we talk about transcranial approaches, the anterior clinoid process is the key point for us when we work through the nose. The key point here really is if you have a prominent middle clinoid process, which you can see here in this dissection, is this piece of bone right here. This is the bone which we remove when it's prominent, so you can gain access to the clinoid space behind the anterior of the carotid, and then you can get a space into the superior compartment just above the horizontal cavernous carotid. In terms of dura, we all remember that we have two dura folds or dura leaves, one called the periosteal layer and the other one called the meningeal layer. So here in this specimen, you can see that we have both layers, and the first one you see is the meningeal. If we peel this layer, we're going to have the periosteal layer, which is basically transparent and allows us to identify the cranial nerves in the lateral wall, the cavernous sinus. And in the endoscopic perspective, when we look at the sella in the paracellar region, things are a little bit different because we also have those two layers in most of the spaces. But in the paracellar region, just lateral to the sella, covering the cavernous sinus, the so-called anterior wall of the cavernous sinus is formed by only one layer of dura, which is the periosteal layer, and they are separated. So you see here the anterior layer separated by the blue, so the layers of the cavernous sinus, whenever the walls are not attached, you have venous blood occupying that space, and that's why you have the cavernous sinus. And then you can see that the medial wall, it's nothing but an extension of the dura that comes from the diaphragm. And here, when I open the anterior wall and I push the pituitary gland laterally, you can see the medial wall isolated and in continuation with the distal dura ring and the diaphragma sella. So in terms of endoscopic and nasal approaches, some of the concepts, in absolutely most of the cases, you don't need to do a transpterygoid approach to get into the cavernous sinus or to transect the median nerve. That is a more important maneuver if you're really going into more lateral aspects of the medial fossa. The medial wall of the cavernous sinus and its removal, it's a technique that we're going to talk about in a second. And, I mentioned that I like the division in two big spaces, but I'm also a big fan of the work done and proposed by Juan Fernandez Miranda and the division in compartments, superior, inferior, lateral, and posterior, based on its relationship with the cavernous carotid artery. This is just to demonstrate that I think we need to continue to push the boundaries and spread the word, and anatomy must always be the key point for us. And we need to teach people about not only the anatomy, but how to have that anatomy demonstrated in a beautiful and accurate manner, just like Evandro always used to say and Dr. Roten always used to say. So here's some of those are my dissections. Some of those are dissections of one of my fellows, Diana from Argentina, and she beautifully incorporated that. And I think that we have the mission to translate that into action to the next generation as well. So going into the step-by-step of an endoscopic approach, the first step always would be to have a big sphenoidotomy and to have a so-called X-ray 3D vision to identify the key landmarks. The first one here will be in the center of the sella, and above the sella we have the suprasellar space that is called the tuberculum as well. And from roof of optic nerve to roof of optic nerve, we got the limbus sphenoidale, plenum, the carotid prominence to the sides that you see here. This is actually the clinoid segment of the carotid. And between the carotid and the optic canal, we got the lateral optic carotid recess, which is nothing but the pneumatization of the optic strut in the base of the anterior clinoid process. All this blue is the cavernous sinus, and here's the clival recess. So usually pituitary surgery, microadenomas, we would open between the four blues, as you see here. But what we need to do today is to really expose more laterally. So when we're working in the cavernous sinus, we really get a more lateral extensive bone removal to really see and expose the carotid, and then we can work within that space. This is exposing the median nerve in the transpterygoid approach, which, as I mentioned, oftentimes you don't have to do here. When we look at the different compartments as proposed as one, the superior compartment has 3 points that are important. It's this compartment that is above the horizontal segment of the carotid. And the 3 points of importance, anatomically speaking, will be the first one, the posterior clinoid process. And when I use an angle in the scope, you can see that in the tip of the posterior clinoid process, you have this ligament called the interclinoidal ligament, and just inferior lateral to it, you're going to have the oculomotor nerve. So when you're working in the superior compartment, you focus on the one nerve that you focus on is the oculomotor nerve. The posterior compartment is one that you're going to focus behind this vertical segment of the carotid, and in this space, the one nerve that you want to pay attention to is the sixth nerve, or the abducens nerve, as it crosses the prepontine cister, Gruber's ligament, below Gruber's ligament, and into the cavernous sinus. The one prominence that is very important here is this so-called petrosal process, so the sphenoid bone that is located just medial to the sixth nerve and functions as an anatomical landmark before you reach the sixth nerve. And finally, there's anterior inferior space, which is basically everything located in front of the vertical segment of the carotid, and laterally you're going to have the lateral wall. Is the one that you got to be careful with when you're working because you have the sixth nerve inside the cavernous sinus. But even that sixth nerve is located in a plane that is just lateral to the horizontal segment of the carotid. So if you're working medial or at that plane at the midline of the horizontal ICA, you oftentimes well protected. And if you're dealing with a pituitary adenoma, usually that adenoma will be pushing that sixth nerve away. So a complete injury of this nerve is extremely rare. And you can mobilize the carotid by opening the medial and, the proximal digitoral rings, and you can basically expose the superior orbital fissure, which is a more unusual maneuver, at least in our experience. And when you try to do that, you got to be very careful with this artery, which is the inferior lateral trunk, so that you don't cause a rupture of this vessel, which basically would translate into a very similar carotid bleeding-like injury that you got to be very careful with. So let's look at surgery. Case number one, this is a 52-year-old gentleman that had two surgeries before in another institution in 2006, 2012. He had a non-functioning pituitary tumor, and the residual was always too close to the carotid, as you see here. So 2016, the tumor started growing again, and got here with this tumor here that you can see in the coronal MRI, had grown significantly into the cavernous sinus on the left side and pushing the optic chiasm and optic nerve on the left. In a sagittal MRI scan, you can see that this tumor was once again extending in the suprasellar space and reaching that cavernous sinus component on the left side. So basically here, as I mentioned, in my opinion, the challenge had always been the cavernous sinus in this patient. So the goal was to kind of try to clean that area and to achieve, a complete removal as much as possible, but also to preserve the function of the pituitary gland. This patient had no pituitary dysfunction. So here, just to show a coronal T2 scan as well. And you can see the tumor extending into the cavernous sinus on the left, optic nerve pushed on the left, and that was causing visual changes, and the gland was on the right side. So I need to know where the gland is to protect the gland as one of the key points for our surgery. I'm going to skip the initial part here, but you see one of the key points is the bone removal. You need to get this wide bone exposure, just like we need in my opinion, in every single skull-based case that we do. I think the bony exposure represents about 70% of the work that we do. Here, working on the left side to drill towards the paraclival ICA, and here I'm already dissecting some of the dura to get some exposure. On the left side, the consistency was okay. On the right side was very, very fibrous because of the previous surgery. And here, once again, I know that my surgery will be based on the carotid, so I need to use a Doppler to identify two segments, or to try to identify two segments. The clinoid segment, which will be fixed by the dura rings, and the paraclival ICA. And when I got that, I can communicate the points. Ideally, this tumor would be very soft, and I could just use bisection technique to protect and decrease chances of carotid injury. But unfortunately, as I started working, the tumor became more and more fibrous. So I literally had to cut that tumor, piece by piece, and use a Doppler as I was doing that. And that's all so I can get the paraclival ICA exposed. I had the clinoidal segment up here confirmed with the Doppler, but I needed to have that space right there. So here, working step by step, here I had found the cavernous sinus, and then what I had to do then was to continue debulking until I got to this point here. You're gonna see that I finally gonna get the white of the carotid here, right there. Basically, this little segment here is my first glimpse of the vertical segment of the carotid in the cavernous sinus. And then basically I have to connect the dots. I have to understand that this vessel has no branches coming from its anterior wall or lateral wall space. So the only one trunk that I'm concerned with is the meningohypophyseal trunk that comes from the posterior geno of the carotid in the cavernous sinus. And then I clean from the segment of the carotid from lateral to medial, and that allows us then to mobilize that tumor. So that's what we're doing right there. Then I can continue the bulk and to create more space. And here in this area is the area that I spent the most time, right here, because I needed to be able to completely separate the tumor from the dura in the posterior geno of the carotid, which is right here. And once I achieved that, then the surgery was mostly done. So what I did then was just to separate the bulk of the tumor, preserving the gland on the right upper corner. And then I could continue dissecting that area with care to avoid a big leak, because this patient already had 2 surgeries and didn't have any significant flap available. And then here you can see the carotid being cleaned up, and you can see this nice view of the carotid vertical segment, posterior geno, horizontal ICA, and anterior geno of the carotid here in the cavernous sinus. The diaphragma cella is going to be seen here in a moment. And you can see here the pituitary gland on the top, diaphragma here, and that's the end of the approach of the surgery, I should say. And then here we got this very, very nice resection with a beautiful cleanup, in my opinion, with the gland preserved on the right side and no tumor seen in the cavernous sinus. So this patient did clinically well. He did have a left partial third nerve for the first 2 weeks. It's basically symptosis, and that recovered spontaneously. We did use a lumbar drain, but we removed it on post-op day 3. He did not have diabetes insipidus. He did not have new hormonal deficits, and he is basically his tumor is controlled for more than 1 year now. Second case, 30-year-old woman with irregular menstrual cycles and a non-functioning adenoma causing some prolactin elevation, but was a non-functioning tumor. And she comes with this MRI here. That is an interesting one because you see the extension into this little space right here. This is the oculomotor cistern. And this tumor, therefore, is likely a soft pituitary tumor that was going into the cavernous sinus and occupying that space. And you can see here in a sagittal view, this area that represents the superior compartment of the cavernous sinus. And here in the top and in the left, this is the pituitary gland. So I needed to protect the gland, clean up the cavernous sinus, and then finish the debulking. Those were the steps of the surgery. So part number 1, big exposure. We need to see the anterior wall of the carotid, the cavernous sinus, and the carotid on the right side. So that's what I'm trying to achieve here. This is the optic canal. This is the clinoid segment here. And the bony decompression had been achieved. So clinoid ICA, anterior wall of the cavernous sinus, and then the cella that had been expanded. We open the dura as usual. And then here in the top, I can identify the pituitary gland and pituitary tumor plane of separation. And that's excellent. Then you see that with this round knife, I just preserved that plane, and I'm not going to touch that gland anymore for a while. So now we work on the tumor. And then as we work on the tumor, you see that I'm not focusing on the bulk of the tumor in the midline initially. I'm focusing on the lateral component within the cavernous sinus. So just opening that cavernous sinus wall, you see here I'm opening the anterior wall and going to open the 2 layers. So separating the anterior wall from the medial wall and opening towards the inferior intercavernous sinus. That separates the two layers, that creates a gap. And here we debulk that bottom part of the tumor, work towards the most superior aspect, and then I have to work, as I mentioned, superior laterally, and I leave this there for now so the diaphragm doesn't fall. And then I continue working towards the superior compartment of the cavernous sinus. And here you can see, as we work in the superior compartment, you see this area right here. That's the oculomotor nerve and the oculomotor cistern. You're going to see in a second a bit better. You can see CSF coming from that space. And after that's clean, then I can remove this component of the tumor to create some more space. And then after that, that tumor is removed. The pituitary gland is preserved here in the top. And then you're going to see with a 30-degree angle endoscope, this nice view here of the oculomotor nerve and oculomotor cistern. The medial wall was preserved in the inferior compartment of that medial wall. The superior part of the medial wall had been removed. Not removed, I should say, transgressed by the tumor. I really didn't see a significant medial wall there. And then you can see here in more detail that nerve in the top. And then this is the interclinoidal ligament here on the tip of my dissector. So interclinoidal ligament, oculomotor nerve, and the carotid here protected by the medial wall of the cavernous sinus. Okay. And this is the resection. Of course, if we achieve those goals, that area would change. So you can see that the oculomotor cistern now is a clean tumor, and that we got this complete removal there. So in terms of tumor-related factors, we need to understand and remember that when we're talking about the cavernous sinus, that cavernous sinus so far is a very small space, but the challenge there is that the tumors usually go either from the cavernous sinus or they go into the cavernous sinus and they go into other spaces. And that depends on the size of the tumor and its locations and extensions, sites of compression, and the consistency of the tumor. In terms of extensions, you can have extensions into the orbit, superior orbital fissure, optic canal, oculomotor cistern, towards the pterygopalatine fossa, infratemporal fossa, vitreous apex, and posterior fossa. So all those points and the relationship with the carotid must be considered. Endoscopically, it's absolutely the same thing. Think about orbit, optic canal, superior orbital fissure, oculomotor cistern, pterygopalatine, and infratemporal fossa, and vitreous apex and clivus. So how does that translate into tumor and surgery? Take a look at this case, 75-year-old man with a 3 years history of a sixth nerve palsy. He was from another state in the United States. He had radiation for this tumor that was considered inoperable 2 years before coming to our center. And then I saw him in New Year's Eve of 2021 to 2022. He had developed basically left trigeminal neuralgia. And he came here with us with this MRI. So this is the coronal MRI scan. And you see this big mass here, center in the clivus, paraclival region, amicus cave, cavernous sinus. And in the axial, you can see that again in more detail. And you can see that the tumor extends here, occipital condyle, amicus cave, cavernous sinus, intradural component in the peritrigeminal area, and left cavernous sinus. So this certainly does not look like a pituitary adenoma. This actually looks like a chordoma or a chondrosarcoma. So what do we do? Of course, I think this is operable. So we do surgery here, and certainly so a difficult surgery because of all that compartments, all the compartments have been exposed. So we start from the right side, and you saw the carotid on the right, and here I'm drilling on the lateral and the border. So I'm going from the right side to the left side to create more space. I'm transposing the lacerum segment. I'm doing a translacerum approach to create space. So mobilizing the top of the station tube, working here in the pterygoid process. So doing a partial transpterygoid approach on the left side now, because I need to have exposure of that Meckel's cave. And then I'm just going to skip the video a bit. And then we get this big bone removal. I need to have the carotid on the left side as well. So I was just exposing that. And then with those completed, I'm going to start working on the right cavernous sinus, where I don't have a lot of tumor, differently from the left side. So I'm going to try to create a plane. So I go from outside the tumor to inside the tumor. And with that work, I'm going to find, you see the clinoid carotid on the right side. I want to identify the carotid on the right side completely. So you see here the vertical segment of the carotid, and I'm cleaning tumor behind the carotid, so towards the petrous apex, and drilling all that bone tumor that is diseased, basically in the clivus. I'm opening the anterior wall of the cavernous sinus and cleaning tumor from the cavernous sinus on that side. And then as I continue working, I'm gonna expedite the video a bit. I'm gonna work on the left, mobilizing the pituitary gland. I find the carotid, and then I need to open. I coagulate and cut the dura ligaments that will allow me to separate the anterior wall from the medial wall, and then to basically do interpituitary transposition so I can clean up the tumor located in the upper clivus. After that, I'm gonna focus again now on the left cavernous sinus and macula cave, and then I'm gonna go and cleaning up the tumor once again from outside to inside. And you see that this is the vertical segment of the carotid that you see right here, and then I'm cleaning tumor in the posterior compartment of the cavernous sinus just behind the vertical segment of the ICA. And as we do that, you're gonna see that we got here both carotids now, the left and the right paraclive ICA. And only after that, cleanup is that I continue working now towards the middle and inferior compartment of the clivus on the left side, going towards the occipital condyle. Only after I clean up that extradural compartment is that I start working around the dura of the clivus, because I know there is intradural tumor. And then I open up the dura, I find the tumor inside in the prepontine cister. And then in an anti-clockwise fashion, I dissect, finding the basilar trunk. Of course, you got to be careful with the VB junction that will be just next here. And of course, you got to do this with very careful microsurgical dissection. So I start to find the left vertebral artery. This is 6 nerves that are being pushed downwards by this tumor. And microsurgical dissection really to separate this tumor from all the small branches coming from the basilar. So you got to be very meticulous with this, and you got to be very comfortable with your degree of experience with microsurgical dissection with an endoscope to do this. So it requires a few years of experience to do this, of course. And then I continue dissecting from medial to lateral, cleaning up the tumor. And this component here was the challenging one because it was just at the trigeminal nerve. So I got to be very careful with that one. And you see that I'm doing like a reverse opening of the trigeminal or the porous trigeminus. We usually go from outside to inside. I'm here going from intradural to extradural to basically mobilize that area. And as I mobilize that area, I can clean up the tumor all the way until I see the trigeminal nerve. And you can see a very gentle bisection technique and going kind of like trying to go from the top of the trigeminal nerve. So from medial to lateral, we can get that area cleaned up. So I finally get the trigeminal nerve exposed here. Then I'm going to remove that small piece of tumor right there. I got that achieved, and then I open that area. And here I'm working behind the carotid, working around the Doralus canal. And usually if the sixth nerve was intact here, I would have to map this with a simulator. Here the sixth nerve was already not working, so I was more aggressive with that since, of course, I wouldn't be able to recover the function of the sixth nerve that was dysfunctional for the last 2 years. And the pathology here had demonstrated a chordoma, actually. So I continue working and cleaning up all that area using angle curettes and a 70-degree endoscope here. I cleaned up to the best of my ability. This is the sixth nerve here going in behind the carotid, by the way. And then after that cleanup was completed, we proceeded with closure, with multi-layer reconstruction, with substitute fat fascia celebrating. This is the result. So we got a gross total resection, and you can see here this nice MRI result. This patient did well for the first 2 weeks, and then he came back with a CLE that was challenging to fix. Did a first attempt, continued leaking, then a second attempt, put a drain, and then that's when he stopped leaking. But he was in the hospital with us for a month and a half. Finally, he did well. He's doing clinically well and got additional proton beam radiation. So the medial wall now, you saw cases of cavernous sinus, and then we got this concept of medial wall. So really quick, we got the anterior wall of the cavernous sinus in here, and then we're gonna have the separation that you can see, the venous, blue venous of the cavernous sinus, and its separation here. You got anterior wall, and just medial to that, you got a medial wall. Those two layers can be separated, as we discussed. The classic technique that I use, at least, is opening the anterior wall, injecting hemostatics that stops the bleeding, and then I identify the medial wall. Then I go back to the cella, mobilize the gland, identify the medial wall, as you see here, and then you identify the inferior hypophyseal artery, the distal dura ring, and then I go all the way to the base of that ring, I cut the base, and then remove the wall. The other way, you can go from the inferior intercavernous sinus, so from medial to lateral, and you can open that space. You could even do it from the superior intercavernous sinus to the cavernous sinus. The only thing is that when you go from the superior intercavernous sinus, you have a much higher chance of a CSF leak. So in those cases, often you can avoid that by going through the base. So the first case, this is a prolactinoma patient, 6-7 years old. And you see, like, it really didn't look like anything special. This MRI tumor had bleeding a bit. And this is the surgery here. So in the surgery, I planned just to do a usual pituitary surgery. So nothing really special initially. So removal of the bone, getting the dura exposed. You saw some components of old blood there. You see some signs of previous hemorrhage. Cleaning up the tumor, just like a usual pituitary. So here, nothing really special. And cleaning up. And then we always interrogate the medial wall. So you see here that I'm trying to clean up the wall to avoid open your wall and so on and so forth. But I really can't separate that tumor. It's just too attached to the wall. So then what I do, I try to go from inferior intercavernous sinus laterally, but my bony exposure is incomplete. It's not enough. So I need to stop. You see some bleeding from the cavernous sinus, which is good because I got that wall, but I'm not going to have control to remove that, in my opinion, here. Well, so I need to stop and then go back and drill this inferior lateral space, so to get exposed and exposed to that close to the Park-Live YCA. So you see here the carotid, anterior wall. This area is right here. This is a safe area, but we need to map with a Doppler. And then I map with a Doppler, as you see right there. And then I'm going to open the anterior wall. And you see here, I'm cutting that anterior wall, creating space. And then, of course, what do I expect to see now? Venous bleeding. I'm using this feather blade to maximize the space. And once that opening is as big as the tip and the hole of my suction, then I can work there. So I control that bleeding, and then I can dissect. So this is the medial wall, and this is the anterior wall. So the medial, I'm mobilizing the medial wall, going with the feather blade all the way to close to the distal dura ring to separate a structure called the carotid clinoidal ligament. And then here in the base, I'm coagulating the inferior hypophyseal artery. And that allows me then to mobilize this dura to identify the posterior clinoid process and then to fully separate this wall so that I can send this to pathology and get a removal of the medial wall completed. So you see here, the medial wall is completely exposed. I'm just going to cut and remove that and send it to pathology. And then after that's done, that's the view that you have. And you can see here the posterior clinoid fully exposed. And that's why such an approach also gives you access to the posterior clinoid as well. Then this is the final result. This is the final MRI scan, but of course the importance is the prolactin level, which went down to 12. And this patient is under disease control up to now, 1.5 years later. Okay, good case, classic technique. What about this one? This is an acromegaly case. You see here a NOSP2, pituitary to the left, tumor to the right. And here I'm going to show you the importance of the middle clinoid process. So just bony exposure, bone drilling and drilling. And here on this side, we're going to find a bony prominence that is the medial clinoid process. So I'm not going to go from medial to lateral. I think that's risky. So I expose the carotid laterally. And then you're going to see that I'm going to mobilize this little piece of bone here, which is the medial clinoid, from lateral to medial. And then we're gonna have some venous oozing. Middle clinoid, not too big. I remove that, some venous bleeding, that's fine, not a problem, just control with hemostatics. And then I continue exposing the carotid, exposing that anterior wall. So you see here, the carotid is exposed. Part of the anterior wall was open. So then I decided, okay, I'm just gonna go and open the cavernous sinus already. I'm cutting the carotid clinoidal ligament, which is basically the continuation, the medial continuation of the proximal dural ring. And then we're gonna see the carotid. So you see here the horizontal segment, the vertical segment of the carotid. And now I'm gonna open the inferior intercavernous sinus. And then after that, I'm gonna go to the sella as per usual, identify the normal pituitary gland on the left, clean up the tumor on the right. And you're gonna see that as I debulk that tumor in the sella, I isolate this medial wall. The medial wall is right here. And then I'm gonna remove that wall and send to pathology. In the most anterior part, I didn't see any tumor, but in the back, I could easily see that tumor that was extending towards the superior compartment. That's where the invasion of the medial wall was located there. And then I transect the wall in the top and then transecting the bottom. I like to leave the bottom as the last piece, just because that's where you're gonna have the inferior hypophyseal, close to the vertical ICA, and that's where you gotta be more careful. You see that I have to cut pretty close to the vertical ICA, so you need to have a good visualization, good control, and a really good understanding of that anatomy to avoid a catastrophic carotid injury, basically. So that's removed, and then we continue the closure. But you see here the post-op MRI and the hormonal control that was achieved in this case. And then final case here, this is Cushing's, and if you're yet not convinced with this, you're gonna see that this patient had surgery, had disease control initially, and came back with recurrence. This is the tumor over the years 2017, now 2022. You see here on the left side. And then what do I have to do? Once again, get that this sphenoid sinus drilled. And this was pretty much a lot of bone again, despite the previous surgery. So find the sella, then expose the carotid on the left, and then after it, basically I see the carotid here on the left. I open the cavernous sinus initially, feather blade to open up those spaces, and then here I'm going to allow me to mobilize basically the carotid from the gland, and then I'm just using the hemostatics to connect that area. And then here you can see the carotid, and this is the so-called inferior paracellular ligament that I'm cutting here. And after I do that, I'm going to go all the way to the top, close to the carotid clinoidal ligament. And you see that the carotid and the tumor, they're very basically adherent right there. So after that part is done, I'm gonna go back to the sella. I'm gonna find the gland on the right side, and then I'm gonna clean up the left side. And you see there's tumor in the sella. So at that point, I was kind of a little bit afraid. So maybe I didn't have to do all of that. So anyways, I continue cleaning it up, cleaning the tumor in the sella. And then you see basically the tumor is mostly cleaned up. And to this point here, I was very happy with the cleanup. But then I said, okay, I'm gonna remove this wall anyways, because that was my original plan. I had already isolated. And as I clean up the wall, I see tumor adhering to the wall in the posterior part. And then I'm gonna see, as I mobilize that wall and I cut it, I'm gonna see tumor coming just from inside the wall. So this is the top in the bottom connection. I cut the superior attachment. I coagulate that inferior hypophyseal. And you see, I'm mobilizing the medial wall. And what do I see here? Tumor. Basically, tumor occupying that medial wall. So all of that was tumor that if I had not done this approach, certainly so would be there and would be residual tumor. And this patient would not achieve disease remission. So we got that removed. And the result was basically, you see here the pre-op scan. I'm sorry, very quick. The pre-op scan here, and then the post-op scan here, where we got that removed. So I'm going to skip this case for the sake of time. And in terms of results, right now I got 205 cases in the last 2 years since I joined Mayo, with 23 medial wall resections and 92% of control. I had 2 cases that did not achieve disease remission, and I blame that on me. I believe that I didn't remove the medial wall completely. but those patients are under control with medical therapy, no carotid injury, no CSF leak. And this is a systematic review that we did. I'm publishing our results now, so should come back in the next few months. And as conclusion, the cavernous sinus is a very complex lesion. Complications can be unforgiven. Multidisciplinary assessment and treatment is required. Radiation may be adequate in selected cases, and we do use radiation for recurring tumors, of course, as well. But in my opinion, I like to explore the possibility of surgery if I hadn't done it before in that patient. Of course, the goals of surgery are different based on the pathology or your experience and the patient itself. And that cannot be done alone. So I'm very thankful for the team that I work with, my colleagues in neurosurgery, Quinones, Chaichana, Dr. Sensen, endocrinology, my ENT colleagues, and also very thankful for the fellows working with me in the lab. And you see a big list of people from many places, and hopefully so we're going to have more people coming and maybe some colleagues from China as well. So thank you very much. This is my email for anybody that would like to connect and to, talk about this and to discuss ideas and maybe to work together. I would be very, very happy to collaborate with all of you and to develop connections with you, my Chinese colleagues. So thank you very much. Appreciate the attention. And well, I think I had 45 minutes, so I have 2 minutes beyond, but appreciate the attention.
João, excelente. Wanley, you're available to audio? Perhaps not. Okay, we'll start a few questions. Okay, Harshad, you have a question, Harshad?
Hi. Hi, Professor. This is Dr. Harshad Parekh, neurosurgeon from Mumbai, India. Hi. Excellent talk, wonderful presentation. And you have shown the wonderful anatomical pictures also, and how to deal with the medial cavernous sinus wall and open the carotids and decompress the carotid as well as excite the tumor. Now, do you feel that we should be doing in all cases this medial wall opening and removing the tumor from the cavernous sinuses? Or there are some indications where you need a surgery. Do you think the SRS will be of great help if we leave this tumor in view of some morbidity and mortality if it comes? What is your experience? Anytime have you encountered the injury to the carotid during these cases you have done? Please explain if you got any.
Thank you very much. Thank you, Dr. Parekh. I really appreciate your questions, and I think all of those are very valid questions. So basically, I started doing this here at Mayo in the last 2 years. So as you saw from the about 205 cases of pituitary tumors that I've done here, only about 10% of them, right, roughly 10% of them, so 23 cases, I completed a medial wall resection. So number one question and answer is no, it's not for every single patient. I do believe, though, that we do have the ability to look at the medial wall in every case. I think that we can check the wall and see if there is invasion. I mean, with the endoscope, not that you need to remove and look with pathology in every single case, but I think you can look at that with your endoscope. So that I try to do, to at least look at it in every case. And it's nice, I didn't include here, but I have some nice images showing a very clear medial wall, which we see, in fact, we see in a good number of cases. Most cases that I do this are for NOSP 2 or 3A and 3B. I don't include the cases that are classic NOSP 4 in this technique or this series, because I think that, really the medial wall in those cases is, destroyed or invaded already. And I find difficult to be able to transect something that I'm going to call medial wall because the tumor already created that space. So that I think answers the first questions. In terms of SRS radiosurgery, I think it's a fantastic tool. I myself, I'm trained in gamma knife and I do gamma knife as well. But what I find is that if a surgery can be offered, as we all know, for pituitaries and offer safely, I think it provides the best option to quickly decrease the hormonal changes. And therefore, I believe this is a technique especially so useful for functioning adenomas, especially acromegaly, Cushing's, prolactinomas, and for those recurrent non-functioning adenomas. And I have to say, for non-functioning tumors, I didn't show this case here, but I had a case that was very fibrous, and everybody here in the department was very excited about the results we're having. And I said, okay, let's do it. And I kind of like already knew it was going to be fibrous, and it was really fibrous. So I had to really dissect with the micro scissor just on top of that horizontal carotid. And everything went very well. But those are the cases that give you a little bit of pause. You know, that's a patient that could also receive radiosurgery for a non-functioning pituitary tumor that was growing again. And one needs to be very confident in your, in your practice. So before I started doing this, I already had about 700 pituitaries or so to before I started doing this. And the final question, no, thank God, I haven't had an actual carotid injury. I did have one case of a prolactinoma that I have to say was one of those cases that was everything very good, last case of the day, and I was finishing the resection, and I was, very confident. I didn't even use the Doppler, and I was finishing the resection of the wall, and I got, a bleeding, a more significant bleeding, and I was kind of, oh, and then I put a patty in there, and I just put some pressure. But then I even called my endovascular colleagues, said, well, I may have a carotid injury here. Everything is under control, but it's 5 p.m. Don't leave the hospital right now if I need your help. Just, end of the day, I just compressed. And as I left, as I removed the packing, was not a carotid injury or anything. We all know that carotid bleedings, they don't tend to stop just with pressure, like you need to leave something behind. And so therefore was just, I fear hypophysio that I had cut before coagulating, but the arterial bleeding looks similar to the carotid. So anyways, those are things that we need to be prepared. But I think just to go into the line of your questions, Dr. Zhao asked here about carotid injury as well, if to have this done in a hybrid OR, if that would be safer. I think that's definitely an option if you have that easily available. The chances of a carotid injury here, if they were very high, if you had a high number of carotids, I don't think this procedure would be justified. So if carotid injuries are happening, I think you need to rethink this technique. Thankfully, that's not our experience.
In cases of acromegaly, when the tumor is going around the carotid artery and you feel the tumor artery is traveling through the acromegaly, the tumor, what do you do? Because the tumor is going lateral to the carotid. Tumor medial to the carotid, yes, I can, with your dissection. If it is going lateral, do you still feel that you should be doing the complete exposure of the carotid and separating the tumor laterally? Is it easy to go lateral to the carotid in this case?
I don't think it's easy. Certainly, so I don't think it's easy. I think it's much more complex. I think that when you look at that area just lateral to the carotid, the way I look at it, I divide it in two areas. One that is a superior area that in fact is the superior orbital fissure, and one area that is inferior to that anterior genial. So that area that is, lateral but inferior to the anterior genial, so not the superior orbital fissure, it's an area that I think we can do surgery well. So I do favor, a complete exposure of that cavernous sinus, and that you can at least interrogate that area if the tumor is soft. You have to be careful with the sixth nerve because that's the problem right there. That's very different from opening the proximal dural ring and to mobilize that anterior genial, which is a much more difficult approach. So I haven't done that. I haven't done through that space. I usually, when I try to go lateral to the carotid within that area, I use angle endoscopes and I try to see what I can get from above the horizontal ICA like this and below like this. But to mobilize the carotid within that area, I haven't done yet. I have to say though, in my opinion, it's a matter of really experience. So I think to me, that's something that I interrogate as my next step, because anatomically you can do that. What happens within that area is that, such as you have in the medial wall, the dural ligaments that connect with the anterior wall that communicates the medial wall, in the lateral space, the dura of the anterior wall extends to the superior orbital fissure and periorbit. And if you have the anterior genital of the carotid and you map that area, you can open that space, and the tumor often creates a space separating the nerves that are lateral to you, basically, and the carotid. So if the tumor is very soft, I think you can have a nice cleanup. If that cleanup will be enough to achieve disease control in acromegaly, that I don't know, because I don't have the numbers to share. But I think it's something that in experienced hands can be attempted. I myself, I haven't done it yet.
My experience is a little different, and I find in acromegaly, the consistency of the tumor is a little different than the non-hormone secreting tumors, and it becomes difficult to suck it out, and they are fibrous. And I'm always scared near the carotid. If anything happens there, it will be difficult to handle it. So we always try to leave a cuff of tumor around the carotid and subject them for SRS. And believe me, the most of the time, the hormonal levels come down very fast. Next 2-3 days, you see the hormonal levels are coming to the baseline, and they are easily controlled by the drugs and SRS both. So this is our experience. It means I am not very comfortable to do it. Maybe I'm not as experienced as yours to dissect it out completely from the carotid artery. And always there is a fear of injury to the carotid artery. So in acromegaly, I'm
I
talking
fully agree
mostly
with
the cases. So I leave
no,
a
I mean, I
cup
think
of
that
tumor.
all of those tumors are got to be, like in the tumors that extend lateral to that anterior genital, my experience is also the same. As I said, I'm interested in checking out my abilities in the future for this, but if it is lateral to the anterior genital, so in the region of the superior orbital fissure, that's an area that I myself today, I do believe in the combination of treatments. And here, it's important to say that in the functioning tumors, even when you're very successful surgically and you have a very nice cleanup, still there is always a possibility of some cells. So you got to be honest with yourself. And also remember that we do have the medication, we do have Gamma Knife, and sometimes that's the best tool. So I think the consistency of I think I fully that if the tumor is too fibrous, and if it is too adherent to the carotid, and that's a case by case, surgeon by surgeon experience, it is you should definitely consider living a little bit for Gamma Knife radiosurgery afterwards. But that I think is a very much case by case and experience case.
Right. Wonderful. Excellent presentation. And I, echo your experiences and the thoughts of the carotid artery. Wonderful.
Okay, we have a question from Ibrahima. Could you please introduce yourself, Ibrahima, and ask your question? Ibrahima, you there? Or perhaps he lost connection. Okay, any more questions or comments from the panel? Okay, very good. Thanks, Zhao. Excellent. It was translated into Chinese, and we got a good audience there. And also it was translated into Japanese by Takashi Khan. Takashi, are you there? Are you available to say hello? Boy, no one's answering today. Okay, Zhao, thank you very much. And I'm glad you got to meet Ben Zhu personally. So, okay.
John,
No, it's
John,
my
can you get him?
pleasure.
I'm going.
John,
go ahead. Yeah.
Can we get Joe again to give
Yes.
more insight on this kind of lesions, because these are something very, very difficult to achieve these resections. So we will learn more from him and more experiences of this. We give him more time to listen to.
Yeah, that's fine with me.
Yeah. That's my request.
I hope. Well, are you up for it, Zhao?
I mean, I'm always available, and I'm more than happy to join you all. I mean, as I was telling John, just for everybody to know, be very transparent. I'm in that trip right now because it's my wife's birthday. But when John, told me that there was this opportunity, I said, well, I'll find my way. And I'm in a hotel room
Yeah.
with my wife sleeping
We'll
right in
push
front of
it.
me here.
No, that's
Happy birthday
okay.
to your wife.
But
Happy
I
birthday.
would not, I would. No,
Okay.
Happy
thank you.
birthday.
That's
I would
okay.
not miss this
We all
opportunity at all because I've been, as I said, I'm from Brazil, and this. I just want to say that I'm from Brazil, of course, as you saw, and I'm a very international person. I like to think, and I'm very knowledgeable about the fantastic work that my colleagues in China, Japan, India, and many other places in Asia are doing. So I'm a big fan of the work, and I'm available and very much interested in working with you all and collaborating with you all. My email is I shared in the presentation, but I want to type it in the chat. So if anybody wants to reach out for us to further discuss, I'm available here. And I would be more than happy to join in future occasions as well. So thank you very much for this opportunity. I really appreciate it.
Yeah, you'll be hearing from us. Okay.
Oh,
Thank you very much.
Ibrahima shared his message.
Oh, okay.
Thank you.
Thank you.
Okay. We're
Thank
going to move on. Go ahead. Did someone say something? Okay, we're going to move on to the next speaker. I believe Wan Lee lost connection, so I'll introduce Ding Ho Wen from West China Hospital. He said, my name's Larry. I didn't know Larry. But anyways, here's Larry. It's all yours.
Yeah, thank you, Dr. Bennett. So I'm going to share my screen first. Okay, here's the slides. Can everyone see it?
Yes, perfect.
Yeah, thank you, Dr. Almeida. Thank you, Dr. Bennett. Thank you, Dr. Zhao, Dr. Xu, for inviting me to this wonderful webinar. And I've seen the beautiful, wonderful presentations from Dr. Almeida, who's a very experienced neurosurgeon and good experience with neuroanatomy. And I am actually very new to neurosurgery, just joined the Department of Neurosurgery in West China Hospital. Probably we haven't been appeared in this kind of webinar for lots of times, so maybe everyone is not so familiar with us. And I hope by this opportunity we can share with you a lot more about our experiences. And today I'm going to share with you one of the very interesting topic that we've been doing for the past 2 years. That's the investigations on the clinical characteristics and pathological mechanisms of blood blister aneurysms. Before I get started, I would like to first talk about a little bit about the rationales we get started on this investigations, on these studies. Because we're situated, our hospital is called West China Hospital. We're situated in the west part of China, which is in the province called Sichuan, and we're very close to Tibetan populations and Tibet. And we find that a lot of people in our places and in Tibet have the blood blister aneurysms, and they're extremely difficult to handle, and which is known to almost all neurosurgeons. And so we're interested to know what are the characteristics, and then the most important question is how are they developed from the internal carotid arteries. And the second thing is that I'm actually when I during my training, I get first started on basic medicine, and so my previous years have been dedicated in basic research. And I was trained under Dr. Yu Chao here in West China Hospital for neurosurgery, and also I did my elective in UMass University of Massachusetts under Dr. Richard Moser, and also I had my postdoc done in Canada McGill under Dr. Jack Antel. And Dr. Jack Antel is actually a neuroimmunologist who was very interested in the single-cell RNA sequencing. And when I was first getting in touch with this technique and get familiar with it, and I find that using single single-cell RNA sequencing can give us a lot of knowledge, especially when we are studying a very small lesion. Because in the past, we do a lot of RNA sequencing conventionally, and we also do some pathological stainings and immunohistory. But the problem is that it does not give you like a chronologically or like evidence as how they developed. So we adopted the ways of single cell RNA sequencing and to study the blood blister aneurysms. So that's why we get started on this in the first place. So I'll get started now, and so my topic will be in these 5 aspects. First, I'm going to give you a very brief overview of what the blood blister aneurysm is like, and then we're going to discuss about the clinical features of blood blister aneurysms, as well as its radiological features and clinical pathological features. And then we will move to the transcriptional landscape of blood blister aneurysms and to get a better and deeper understanding of this lesion and how they actually develop, and maybe just provide one of the possibilities that can cause this disease. So from the literature review, we can see that the definition of blood blister aneurysms refers to the often pseudoaneurysms that are located usually on the non-branching side of internal carotid artery. So the first description of blood blister aneurysm can be dated back to 1979, where O'Hara and colleagues described a series of 1,116 patients with internal carotid artery. With intracranial aneurysms. Among these patients, they identify 11 cases of aneurysm that's located on the non-branching sides of intracranial arteries. And they call them very unusual and very rare aneurysms, but they did not give a specific name for these aneurysms. And then further, in 1986, Nakagawa and reported once again on this type of aneurysms. They reported specifically on the internal carotid arteries, and they presented 8 out of 460 cases, and they refer them to the orphan aneurysm because they sprout on the non-branching sites of internal carotid artery, unlike the other barrel-like aneurysms where the often initiated on the branching sites and the bifurcations. And not until 1998, when the Japanese pathologist Ishikawa performed an autopsy on the SAH patients who experienced the repeated subarachnoid hemorrhages and was sent for autopsy for a reason, and they eventually described this kind of lesion as a blood blister-like aneurysm because they look like the blood blisters. And on the right side, we can see that's the figure, the original figure provided by Dr. Ishikawa, and the highlighted area was the proposed blood blister aneurysms. And ever since then, the pathological study and how they were initiated and seems to come to a halt. And not everyone, not a lot of neurosurgeons or neurologists are interested in this lesion, especially how they initiated. So the etiology of blood blister aneurysm actually came to a myth, and no one actually carried forward how they developed. But a lot of clinical series, of course, were carried on to summarize their clinical features. So in our center, we first carried out a very pilot cohort study using 155 cases of patients with blood blister aneurysms. We find that the blood blister aneurysm actually accounts for 1% of all intracranial aneurysms, and they account for approximately 0.9 to 6.5% of all ICA aneurysms, and 0.5 to 2% of all the ruptured intracranial aneurysms. And they can be found in all populations with similar incidence. However, as I just mentioned previously, that the Tibetan population prevalence is observed a little bit higher in our center in West China Hospital, accounting for more than 30% of the patients. Of course, we believe this has something to do with the etiology, but exactly how it came into place, we're not sure. We're still looking into it. And the average age of patients developing blood blister aneurysms, 47.5 years old, and with a little bit female predominance, and approximately 2 versus 1 female versus male. And we have observed a very significant delay from onset to admission and onset to diagnosis. and which is saying that approximately in our center, we take the patients in, and before and the time from their symptom onset to the admission actually can vary from 3 to 8 days, and we also believe that's probably one of the reasons, and that leads to the following observations. And then we summarize a little bit on the radiological features of blood blistering aneurysm. We find that blood blistering aneurysm can be can progress very rapidly, because for a normal aneurysm, they can grow like 1 millimeters a year, and that's probably the common speed. But for blood blistering aneurysms, they can grow very fast, and we have a summary of the data in the following slides. And they are following that, like as we said, like the 32.1% of blood blistering aneurysm can grow during their admission, and they grow following the 3 patterns. One is from normal artery to aneurysm. Of course, they have preceding subarachnoid hemorrhage, and the second pattern is that they can enlarge in size, and third is that they can develop daughter sacs, which we show on the right side. And those are the 3 type of patterns that we observe in our clinical practice. And blood blistering aneurysm is actually very difficult to diagnose in initial digital subtraction angiography, because a lot of BBAs in our practice actually was diagnosed retrospectively after the surgery. And before the surgery, actually, it is really hard to make the actual diagnosis. So repeated CT angiography and the DSA can reduce the misdiagnosis, and it is recommended to be done multiply in 3 DSA for the patients with recurrent subarachnoid hemorrhage or the insidious subarachnoid hemorrhage. So we have 1 suggestions over here for adults with non-bifurcating intracarotid artery aneurysms whose tip pointing dorsally or ventrally with irregular aneurysm morphology. Diagnosis of BBA should be considered. Okay. The morphological aspects, we summarize that the average blood blistering aneurysm diameter is actually very small. It's approximately 3.3 millimeters, and with a wide neck at the non-branching sites of internal carotid arteries. Although the blood blistering aneurysms are often found in the dorsal ICA, but it can also, in the previous literatures, it was also found on some other intracranial arteries trunks, like anterior communicating arteries and metacerebral arteries, and they always carry with very severe symptoms, high SH, Huntington's grade. And in our observations, we have found that they can present actually in 4 types, and I think that's pretty much this probably something new for some of our audiences, because normally we believe that the type A or the type B could be the blood blister aneurysms, but actually in combined with the gross pathology and the radiology workout, and we can find that they can also present like a cocoon or beads, like they shows as like longitudinal fusiform expansions, and even for and the last type, the type D, they can involve all the feeding arteries or the parent arteries. They can be like an erosion of the whole parent artery. Actually, those are the 4 morphological types in DSAs or in gross pathologies that we summarized for blood blistering aneurysms. Now we have made a very interesting calculation that the average progressing speed, because we have some of the blood blistering aneurysm that is progressing very fast during admission. The average speed can reach 0.45 millimeters per day, and the fastest progression can we encountered one of the patients who just grow from no aneurysms to 3.5 aneurysms just within 2 days. So it can develop really fast, and the average size is actually a bit smaller. Then we move on to the clinical pathological features of blood blistering aneurysms. We've done the pathological stainings, and first we compared the normal arteries and and the regular secular aneurysms and the blood blistering aneurysms. For ethical reasons, it's impossible to gather like a completely healthy arteries from the brain, like intracerebral arteries, but we try to use the middle meningeal arteries as a good comparison. And on the left side, we can see like they're aligning in the textbook structures, and in the middle we can see that's the normal secular aneurysms. We can see a dense fibrous proliferations, and which is the compensation for the lesion damage. And on the right side, most outer right side, we can see the blood blistering aneurysms. They're just thrombi with they're just absence of any tunica media and tunica intima, and the aneurysm neck is a remnant arterial adventitia and thrombi, and the aneurysm wall only retains a very small portion of collagenous adventitia. And the main body of the you can only see that a lot of abundant infiltrations of inflammatory cells, and we're not seeing that, like the normal structures, and which explains to some extent like why they expand too much, and why some of the previous researchers claim that they are like the pseudoaneurysms or the dissecting aneurysms. We've also performed the scanning electronic microscope, which reveals the very loose collagenous structures of the blood blistering aneurysms compared to those secular aneurysms. Although secular aneurysms are also diseases or like dysfunctional structures, but they still retain the part of the, or I would say 60% part of the normal functions of an artery. And based on the basic pathology, we move on to the immunohistory stainings, and we find that in the stainings, the blood blister aneurysm actually not only lack all the intima, tunica intima, tunica media, they also lack elastic laminas, and elastic laminas are just absent. And the normal structures are absent in blood blistering aneurysms, confirmed by the staining of GLUT1, alpha SMA, and also the fragile aneurysm neck is composed of very thin fibrous outer membranes of the significantly reduced collagen content, and the structure characteristics of none of the pseudoaneurysms actually resembles a dissecting arterial aneurysms. And we can see from the left side is the loss of endothelial cells, marked by GLUT1 staining, and in the middle we can see these two figures representing the normal arteries, and this one representing the secular aneurysms. And in blood blistering aneurysm, the vascular smooth muscle cells is often absent, or you cannot just find a very, very small remnant of vascular smooth muscle cells. And on the right side, we can see that for regular secular aneurysms, the fibroblasts are actually proliferating and to compensate the structure, the damage of the structure, and the blood blistering aneurysm actually is reducing in this amount, and which causes the loose and very fragile structure of the blood blistering aneurysms. But in this point, I would like to emphasize that the clinical, the IHC or immune fluorescence stainings can be misleading because of the pseudopositive and the pseudo-negative stainings, and when you adjust the light and the intensity of or the ways you imaging, it can cause a disruption in your understanding. So we would like to perform like a deeper understanding or deeper sequencing of the how this aneurysm actually is consisting is made up. So we designed a very interesting experiment. We harvested one blood blister aneurysms. Actually, in the end, we only get one blood blister aneurysm sequencing done, but actually we performed a lot because of lots of reasons. Those were not those were invalid for analysis. Only one were qualified for final analysis, and we also obtained two regular secondary aneurysms for analysis, and all of them were sent for cell dissociation and signal RNA sequencing. And then we provide them the landscape and just do the annotations, and we find that we, for a subcluster analysis, we find different clusters of cells, and we find the T and NK cells, B cells, and endothelial cells, vascular smooth muscles, and monocyte macrophages. And it is interesting when we provide the cells originated from two type of samples, we can see that the blood blister aneurysm actually lack of significantly a number of vascular smooth muscle cells over here, but they still have some remnant, but they are really abundant in macrophages and monocytes. And so that's those. So we believe those are the two main players in the development and the initiation of blood blister aneurysms. So that's what we summarized over here. They have predominantly mononucleoside and macrophages as inflammatory cells, while the lymphocytes, VSMCs, and endothelial cells were significantly reduced in blood blister aneurysms. Then we move to look at the very small amount of vascular smooth muscle cells, because we believe they made up the remnant structures of blood blister aneurysms, and those cells who survived from this drastic damage might give us a hint of what exactly happened before the initiation, before blood blister aneurysms. So we performed the gene enrichment analysis for the VSMC cells found in blood blister aneurysms, which we can see over here. The cells from blood blister aneurysm is actually a very, very small portion. And when we do the differential gene expression analysis, we find that in blood blister aneurysms, the overexpressed genes are more enriched in inflammatory cytokine receptors, extracellular lysosome, and also the atherosclerosis, arteriostenosis, and arteriomineralizations. But for normal secondary aneurysms, despite although they are like damaged structures and there are also lesions, but the vascular smooth muscle cell controls are increasing. They're increasing the tight cellular junction expressions over there, and the regulation of cytoskeletons, which indicates that for the secondary intracranial aneurysms, the structures are more prone to repairing, whereas for blood blister aneurysms, those inflammatory signs are more enriched in this analysis. And for enrichment, we used the KEGG enrichment analysis, and we find all this already high expressed genes were enriched in physiological or pathological process like arteriosclerosis, vascular mineralization, which indicates that probably to a large extent that before the onset of blood blister aneurysms, there was a lesion of intracranial artery stenosis or atherosclerosis happening on these arteries. They're not simply or pure lacerations or damages to the artery. They have preceding damages to the intracranial arteries, and they also, of course, they have a loss of vascular contractile functions. And then we move to the inflammatory cells analysis. Actually, when we do the analysis, it was the other way around. We first dig into the inflammatory analysis, as most of the other diseases do. However, we found that the inflammatory process of the blood blister aneurysms might not be like a trigger. It was results rather than the cause. So we actually put the VSMC's analysis first, and then we move to the analysis of the macrophages, as we mentioned in the previous slides. That this is the other part of the major players in blood blister aneurysms. We find that in blood blister aneurysm, macrophages linked to arterial atherosclerosis and lipid metabolism. This is very inconsistent. This is very consistent with what our observations in VSMCs, and the inflammatory pathways were linked to interleukin-17, TNF, and kappa beta and stuff like that. And so the inflammatory cells are also shown like the similar gene enrichment as shown in the VSMCs. The macrophages are enriched in pathways involved in atherosclerosis and chronic arterial inflammations, which is shown over here. And then we get started on to look into how the cells were communicating and what exactly is there like a messenger that carrying the interactions from macrophages to the VSMCs or from the VSMCs to the macrophages, and we performed the intracellular interactions analysis, which we find that one of the possible pathways, which is the osteoponin integrin pathways. And we have shown over here that the SPP1, which is programming the osteoponin protein, and actually this signaling pathways acting very actively between the macrophages and the one subtype of VSMCs, which is the VSMC subgroup 2, and which is also one of the major remnant VSMCs in blood-vessel-like aneurysms. This is shown over here, how they interact with each other and how strongly the macrophages subgroup 1 is interacting with the VSMC subgroup 2 via the SPP1 mediated cellular interaction pathways. And in the end, we performed the immunohistochemistry for validation because the pure RNA sequencing can also give us some of the wrong answers, or maybe the false positive. We did a lot of IF and IHCs to validate our observations, that we find the BBAs were actually the mature and the functional VSMCs were decreasing, and the collagen compensation is decreasing, but the osteoponin level is increasing. And osteoponin is actually a protein that can help with vascular repairs and the collagen fibrosis, which we see the increasing of the osteoponin as a very important communicating way, and also a way of compensating all those drastic damages in blood-vessel aneurysms. And in the following, we also stained some of the markers and the clusters and for immune cells, which we find the ApoE positive macrophages is significantly increasing in blood-vessel aneurysms, and ApoE positive macrophages are actually also considered as one of the markers for atherosclerosis in previous researches. But we did not find any other significantly markers that related to the development, or we would say like the markers of blood-vessel aneurysms, because in previous studies we tried to see that whether the M1 polarized or M2 polarized macrophages is associated with the development or the initiation of blood-vessel like aneurysms. But although in the first analysis we adopted some of the samples and believed that part of the polarization functions of macrophages actually was doing something in this, but after single-cell RNA sequencing together with the immunostainings and flow cytometries, we finally conclude that it was probably not right in the first place that to consider that the polarization of macrophages actually plays some role in the initiation. It can probably be a false positive or like a artifact when we do in the experiments. So we reached a conclusion that the etiology of blood-vessel aneurysms can be closely related to a very severe atherosclerosis in internal carotid arteries. Although because when we're talking about the blood-vessel aneurysms, the pathology, there was also involved in the etiology of the initiation of the blood-vessel aneurysm. and the progression of blood-blister aneurysm. What we see in clinic and in gross anatomy is actually after the progression of blood-blister aneurysm. The progression can be caused by like a sudden movement or high blood pressure or like a dissection of the arteries, but the initiation is actually what we're major focusing on in the aspects of this transcriptional study. We believe that the severe atherosclerosis I'm sorry, severe atherosclerosis could be one of the preceding factors. Okay, so this is a very brief summary of this study. We have done some of the clinical retrospective analysis to summarize their clinical features. Despite the distinct features in clinical baseline, the diagnosis can still be difficult for initial clinical encounter. And that's one of our questions to carry out more or further BBA clinical trials in the future, because for an aneurysm you cannot diagnose initially, and how can you just randomize them or attribute them into some of the treatment groups that you're looking for? And even for the latest subarachnoid hemorrhage guidelines, we can see that it is recommended that the subarachnoid hemorrhage should be initially treated or managed by pipelines and endovascular flow diverters, but how to diagnose them more accurately should be one of the topics in the future, and maybe incorporating the findings, the pathological and the transcriptional findings we have described here could be one of the ways, but we still need to expand the study populations. And second of all, the definite diagnosis of BBA is based on gross pathology, as I just described, especially during the surgery, but the radiological features can be important assistance. As we just shown above there, some of the signs can be very indicative. And third part is the etiological factors contributing to BBAs may vary, but severe preceding intracranial atherosclerosis could be one of the causes. And finally, highly cautious of insidious BBAs, because they exhibit, especially when they exhibit like the fusiform Malbury-like granulation-like aneurysms with daughter sacs, especially those ones with irregular shapes. Thank you, everyone. And that's pretty much all of my presentation, because I was told I only have like 25 minutes. So I didn't expand this topic so a lot, and it just limited to a very, very small questions.
Okay, very good. Thank you for your dedication, Dr. Wen, and spending your time to come with us today. Okay, anybody have any comments or questions they would like to address to Dr. Wen? Very quiet audience. I guess some people are at work. I'm sure you understand that, Dr. Wen.
Yes.
And they can't really talk. But I just, what I was interested to hear, I'm not a neurosurgeon, so I can't question you about the text of your content. But what you said, do you do much? You said you've done a few Zooms. You haven't done many Zooms?
Zoom, you mean this webinar like that?
Yeah, conferences.
Yeah, because I'm kind of new in this area, and not a lot of invitations were sent to me. I'm probably sent to my previous my seniors, and
okay.
Yes, this is my very first opportunity to share my research results with everyone.
Oh, okay. Okay, very good. Certainly, we're willing to collaborate with you because West China is a huge area. And as we said, everyone pays attention to Shanghai and Beijing. But yeah, I think we should explore having a regular webcast from West China. If you, we'll talk about it. Just think about it.
Yeah.
Think about it, and we'll communicate.
Yes, because I'm working under Dr. Yu Cha, who's the primary investigator of Interactor 3, which is a very recent big publications in Lancet, and they might give some of the webinars and or the lectures in urology, and because it's for intracerebral hemorrhages, it's a mutual diseases for two disciplines.
Okay. Okay, very good. Okay, we'll stay in contact and we'll move on to, we have to move on to our next conference, which for, let me screen share it to let people know in case they want to come. And Dr. Wen, maybe, let's see here, you might be interested also. Okay, let me screen share just like you guys do. Okay, I'm Sherian, neurosurgeon from Nepal, originally from Nepal. Now he's in southern India. He's going to go over one of Dr. Lawton, one of his operative videos. And Dr. Wen, if you'd like to see a good series of videos on operative neurosurgery, Dr. Lawton has an awesome series, and we essentially dissect the 8-minute video. They're just small videos, 7-minute, 8-minute, but he goes over the video slowly, the 8-minute video, and he asks for audience reaction. So and question. So that's in the next hour. So okay, thank everyone for coming, and thank especially Dr. Wen.
Thank you so much.
Okay, bye-bye.
Bye-bye.